a webinar about 2 and 3 plane fracture in childhood. Diagnosis, analysis, and the treatment. And as you know, this is a very tricky fracture, and a lot of you perhaps have participated also some workshops about this fracture, and you have seen then also how tricky this fracture is. So the learning outcomes today after my talk, you should recognize 2 and 3 plane fractures. You should describe the relevant anatomy of this fracture. You should also classify the 2 and 3 plane fractures. You should evaluate the technique to reduce and fix such a fracture with the cannulated screws, and also what is very important is the situation that you anticipate and address complications. The content of my talk are these 7 points. I will start with the description, then we see the pathophysiological and morphological consideration. Diagnostic is an important part. Assessment is important according to the diagnosis. Then, of course, the treatment. And we have to speak about complication and pitfalls. And at the end, as always, the summary. I start with the description. First, with the 2 plane fracture. What you have to recognize, it is always a Salter-Harris type 3 fractures. And the fragment size depends on the situation of the physis. I will just explain a little bit later, but you see it here. If I have a wide closed physis, then the fragment is very small. If you have at the big closure only on the medial part, at the beginning of the closure, and you have such a fracture, the fragment is much bigger or extra-articular, as you can see here. But all these are 2 plane fractures. I like the word trio fracture much better than the 2 plane fractures. Again, it's always a Salter-Harris 3 type fracture. And why we have these 2 planes? Look here. Here, this plane, this is the Salter-Harris, this is the epiphyseal fracture. We see here this plane here, according to the graphic. And in addition to this, we have the epiphysiolysis, as you can see here. So both together are 2 different planes, perpendicular each to other. Localization. Of course, the fracture occurs always on the lateral portion of the distal tibia epiphysis, and it is a result of the external rotation and stress on the anterior tibiofemoral ligament, as you can see here. And it is a fracture always in adolescence. That means, as I mentioned also before, the medial part of the epiphyseal plate closed, lateral part is still open. So this is really a fracture in this age group. What is about the 3 plane fracture? This is a little bit more complex. The Salter-Harris type 4 fracture of the distal tibia, but in 3 different planes, in contrast to a normal Salter-Harris 4 fracture as we've seen perhaps on a medial malleolus. And again, it's a fracture in adolescence. Closed physis around 11 to 15 years. The fracture line occurring in 3 planes, as mentioned before, axial, sagittal, and coronal planes. So we have a vertical fracture through the epiphysis, a horizontal fracture through the physis, and the oblique fracture through the metaphysis. As you can see here again in this graphic. Again, we have this part in the epiphysis as a Salter-Harris 3 fracture. Then we have the epiphysiolysis in this plane. And now, in addition, we have the metaphyseal fracture in this part. So there is a combination of a Salter-Harris 2 fracture and the Salter-Harris 3 fracture. Overall, it's a Salter-Harris 4 fracture. If we have a look on the X-ray, you see this very clearly. So in the AP view, as you can see here, you have a fracture line up to here. But this fracture line you can see only in the AP view. In the contrast to this, in the lateral view, you see these fracture lines here like a Salter-Harris 2 fracture. So in combination of both, we have then a triplane fracture. Pathophysiological and morphological consideration. This is very important for this fracture. Again, the age is important. This fracture occurs around puberty. That means between 12 and 15 years, depending on the gender and also on the culture and so on. You know, today the kids have a different evolution in this age group. The mechanism, this is a little bit unclear for 2 and 3 plane fractures. But under the line for the 2 plane fracture, the foot position is a neutral injuring force in external rotation and supination. In the triplane fracture, the foot position is unclear, unknown, and the injuring forces, external rotation and supination, is again in this for this fracture responsible for this fracture. You will see this later again in the graphic. What is important? Again, external rotation, as you can see in the arrow here. This is important. But the other important part is the syndesmosis here. And this is an avulsion fracture of this part here, around here. And if the foot goes in a lateral position, okay, you have this fracture here as a Tillaux fracture. And the same, perhaps, depending on the situation of the physis, you have also in a triplane fracture. But this is important to know. Look at this X-ray here regarding the age. When the physes are completely open, the same mechanisms produce a Salter-Harris 1 fracture, as you can see on the left side here. Typical situation, you have epiphysiolysis here with the fracture of the fibula, epiphysiolysis here, or you have then a Salter-Harris 2 fracture, as you can see here, with the fracture going down here and here, but no fracture in the ankle joint because the physis is open. This is in a younger child, the same mechanism. So, why in this age? Again, the reason lies in the nature of the physiological closure of the physis of the distal tibia. The start just of the center medial side, as you can see here. This is the part where the physis starts to close. And then in the next step, the closure goes not to lateral, closure goes to medial, as you see, and completes medially. And then in the next step, it goes to lateral and centrolateral, and as you can see very clearly on the posterior as well on the anterior part, we have not closed physis here. And of course, at the end of the growth, we have the complete closure. This is important to know. Again, you see here what happens from medial to posterior and lateral anterior. Again, in the AP view, you see this very nice Salter-Harris 3 fracture in a plain X-ray, if the X-ray is correct. And on the lateral position, you see a Salter-Harris 2 fracture. Remember my graphic with the planes. If you see these types of fracture, the combination of a Salter-Harris 3 and the Salter-Harris 2 fracture in one X-ray or in 2 different X-rays in 2 different planes, it must be, always must be a triplane fracture, no doubt. You see the line here and the line here. So therefore, I came to the first question to know if you understand what I explained before. Why we do see the 2 or 3 plane fracture only around or after puberty? Because of the bone quality, it's a hormonal factor responsible. It is the situation of the physical closure. It is also the ligament responsible for this because it's stronger than the bone, or is the situation of the physical closure, and the ligament situation responsible? Please vote. I can see you voting. Okay, you see the results in the meantime here. The majority have voted for 5. In my opinion, this is important, it's correct. But also 4 and 3 are correct. But it's mostly the combination of 3 and 4. But nobody recognizes clearly what is the effect of the ligament. So can we go back to the presentation? So therefore now I will give you the answer. You see, the physis starts to close from medial to lateral, and because of the strong syndesmosis, we get a bony lesion. You can compare this to the tibial spine fracture, where is also the bone weaker than the ligament. So this is a protection of the child's body from severe injuries. And the same mechanism we have for triplane fractures. Diagnostic. Of course, if a child with an ankle joint injury comes to the hospital, you go to the X-ray department and ask for an X-ray. But especially in this fracture, you have to ask for a perfect X-ray. That means ankle clear AP and lateral. And if you are in doubt, you can make also an oblique view. And mostly you can see then the fracture. As you see here in this X-ray, again, you see the Salter Harris 3 fracture line, very clear. The physes here are still open, so this is a not typical case, but anyway, you see the metaphyseal part as well of the epiphysealizes here. So you have 3 different planes. In diagnostic, we see a lot of mistakes. Why we see this? First of all, as you can see on the picture here, the insufficient picture quality. If you have a picture like this, how you will make the assessment of such the picture, how you can make the decision for treatment. Okay, mostly in this situation you go for a CT scan or MRI, but anyway, you can avoid this by a good X-ray. The complexity is not sufficiently shown, also because of the X-ray, and again, the insufficient picture quality leads in a wrong therapeutic decision. And at the end, also, if you see not so many or not so often such an injury, you have less experience, okay, the assessment is also very difficult. And you have to recognize on the X-ray that you can see individual different fracture lines. So the question, do we need then, if the diagnosis is so difficult, more than only a normal plain X-ray? Do we need CT scan or MRIs? If you have, as I mentioned before, a perfect X-ray and the experience and your is good and you understand, and I hope you do this after my talk, the fracture in our hand today, we never go, or cannot say never, but very seldom we go for a CT scan, not for an MRI. I will explain in a short moment when we go for a CT scan in which situation. That means exactly what is written here. If you are in doubt, if you see not the fracture very clear, you go then for a CT scan. But again, as I mentioned before for the X-ray, the CT scan is not only a CT scan. We need a CT scan with high quality. We recommend 0.5 or at least 1 millimeter cuts. And as you will see later, 2D reconstruction and not always the 3D. It looks very funny for the parents, but for the decision, the 2D is much better. So the MRI in the emergent situation is problematic. It's more for secondary diagnostics. Excuse me. So here, such a situation. You see this X-ray, a mistake. The fracture was underestimated. You see the arrow. Perhaps you see the fracture line. But if you go for a CT scan in this situation, and this is now the unclear situation, in the CT scan, you see the gap. And when you know now the gap, you can see it also much better in the X-ray. Now you see the gap is exactly here in the X-ray in this part. Perhaps with the oblique view, you can see this also in a better way. Also here, we say it's an unclear situation. Have we an intra-articular or extra-articular fracture? What we can see here is in the AP view, a fracture line like the Volkmann fragment. We see here a gap or a step. It's a step as a sign of a Salter-Harris 2 fracture. But on the other hand, we see some problem here. Perhaps on the computer or the projection is not so good. So this is again a situation for us to go for CT scan. And then the CT scan shows this. This situation is clear like the X-ray lateral. It's the same situation. But now you see in the AP view, we see this so-called three-plane extra-articular fracture. As you have seen at the beginning, that means this is at the very early time of closure, because you see only this part of the physis is closed. So this is the situation of the early physis, and we go to the CT scan. Here again to show you the effect of 3D reconstruction. Of course, the modern CT scans and the computers, they have a button to press, and you can press it, and then you have immediately a 3D reconstruction. But as you can see here on the 3D CT scan, here you see on this side, you cannot see very clearly the fracture, and on the other hand, you cannot see what happens in the joint. You have not more information than this or this. Only if you go for 2D reconstruction, then you see the clear situation. So now in this situation, you see this is an incomplete fracture, ends here. You cannot see this here. And this explains why we have no fracture here and only the fracture line here. So again, I vote for 2D reconstruction. So this is demanding for your radiologist to do this in a good way. Here another example, 3D, 2D reconstruction, and you see the information for me for the treatment is much better in the 2D. The 2D shows displacement better, especially in the joint surface, than 3D. Here again a series of different cuts, and you see the fracture very clearly. And we will discuss this later. You know that from other fractures around the elbow, this famous 2 millimeter gap, 2 millimeter, you can measure only on a 2D reconstruction and never on a 3D reconstruction. Here we see two videos, and here again for a 3D reconstruction. Have a look on this video. You see here a complete fracture also on the posterior part. You see this looks similar, and it's very interesting. In this case, you see a big displacement in the anterior aspect. Now in the other video, you see a much higher displacement to lateral, you see? But now look on the posterior part, we see no fracture outside. But anyway, in the joint, we must have a big gap and a big step in this situation. And in the 2D reconstruction, we can see this much better. Thank you, Rudy, for the video. Okay. So why is this so important? Of course, decision making. Can you see here? Okay. So again, assessment for the treatment. As I mentioned, this is a unique age group between 11, 12 to 15. But independent of this, you have to have a look on the patient. Not every patient looks. It's a mature patient, especially girls. And then on the X-ray, you have to see on the growth plate situation. Because, as you will see later, we can and must cross the physis with our implant for a good fixation. And no growth arrest has to be expected. We are, remember, at the end of the growth. And again, therefore, only at this age we see this fracture. The treatment. What is the aim of our treatment? Of course, to restore the congruency of the ankle joint. And we will not have any step or gap at the end of our procedure in the joint surface. We need a stable fragment fixation to prevent secondary displacement. Therefore, note, the ankle joint again is always stable because of the intact syndesmosis. At every course, in every presentation I give, this is always the same question. Why we have not to fix the fibula for a stable ankle joint? This is again completely different from adults, as you can see here. This is important. Remember the tibial spine fracture. Now we have to decide when we go for a non-operative treatment. Of course, as always, if we have an undisplaced fracture, if really the real gap in the CT scan is less than 2 millimeters, if a closed reduction and stable situation can be achieved, or especially mainly if we have what is the most and the frequent situation, two fragment type. That means two plane and simple triplane fractures. We will see later the other types of three-plane fractures. How we do this? With a below knee cast for 4 to 5 weeks. We make an X-ray control after 7 to 10 days. If we see then a secondary displacement more than 2 millimeters or different to the X-ray, initial X-ray, we go to the OR for a fixation. And some advice, addition to that, what I have written here, like in the radial condyle fracture of the distal lateral humerus, we make the X-ray control without plaster cast. If you have a thick plaster cast, you cannot make the decision or the assessment if you have a changing in the displacement or not. So therefore, you can remove the plaster cast or make the X-ray because you applied the plaster cast because you believe this is a stable situation and this is an unstable situation. So the plaster cast does not reduce the fracture. The plaster cast fixed only the foot and the ankle joint in the movement. When we go for an operative treatment, of course, the rest, that means displaced fracture with gaps or steps over 2 millimeters. If the fracture is irreducible and unstable, and of course all the complex fracture, as you can see on the right side below, a 3-fragment type two-plane fracture or epiphyseal fracture. Of course, the dorsal part you have to open for reduction. The surgical technique for 2- and 3-plane fractures. Okay. I have sometimes a look shortly to questions if I have to answer question immediately. Okay. There is a question again. I come back to this question immediately now. The question is from Brazil. You don't use above cast first to conservative treatment for 3 weeks? Now, this is really different to long bone fractures. As with a rule, we have to go over all the adjacent joints. Here we have to stabilize only the movement of the ankle joint. So you can go only by a lower leg cast. Okay. Now to the surgical treatment and technique. The goal also in the surgical treatment is a closed reduction. You will see this later in the joystick technique, and this is in my hand, in the most hand normally possible. This interposed periosteum is a fairy tale situation. We say, okay, this is in my mind not the problem of the or not reducible fracture. Successful closed reduction, unstable. Okay, we have two possibilities. Percutaneous Kirchhoff, but this needs then additional splinting. But in our hand, we do this today with the modern cannulated screw. It's much better, gives higher stability in the article surface, and mostly we give no plaster cast in addition. Again, percutaneous reduction fixation with cannulated screws, no plaster cast. X-ray control, not after 2-3 days, because we make a fixation. The X-ray control after 28 days means 4 weeks as a consolidation control. And then we start weight bearing and mobility. And the most frequent mistake is that we make sometimes in very simple fracture too much treatment, and on the other side in complex fracture too less treatments. So here are some examples now. A simple X-ray, no CT scan. Where is the fracture? The fracture is here, and the fracture is in addition here. The fragment is here. Okay, so we have to push back this fragment to the correct position, and the syndesmosis is also intact. Okay, how we do this? This picture I have from Jean-Michel Claver. This is a Salter-Harris 3 type fracture. An exact reduction, we can perform this with a joystick technique. That means with a second Kirchhoff wire, and then osteosynthesis with Kirchhoff wire or cannulated screw. And I can say in our hand, over the last 30 years, always closed management. Very simple instrumentation. You see only here the simple equipment. Today we have self-drilling, self-tapping screws, so we don't need to drill. But if you have the older screws, then you need to drill. Then we wrap the patient in this way. We make the drawing on the skin and visualization on the intensifier. And in contrast to this example, I prefer, and I will explain later, to go in an oblique way. So you have a pressure upwards and to medial. Then you bring in the guide wire, and then over the guide wire you screw, and then you close the wound. What is an important, or what is a very frequent failure? Normally we say such a screw is a lag screw, but here we use it as a compression screw. That means the indirection fixation of a two-plane as well as a three-plane fracture is to push the fragment to the tibia and not to pull the small fragment from the opposite side. That means the screw goes always from lateral to medial, from anterior to posterior, and not in this way. This gives not a good fixation and not a good reduction, because you push the fragment away. Here an example with a washer. Personally, I don't like the washer so much, but if the bone is very weak, you can use a washer. Here now from the workshop, some pictures. You see here the fracture exactly on the lateral part here. The direction of the screw in this way. And here you see the obliquity of my guide wire goes up through the physis in this way. So with one maneuver, I make compression to medial and compression upwards. This is a vector calculation. Treatment three-plane fracture in the same way. Again, you see here, you have here in the two-plane, in the AP view, the fracture in the ankle joint, and in the lateral, thank you, Rudy, here the fracture line here, and in the lateral position you have the fracture here. Okay, so it must be the combination of these two fractures. This is a 14-year-old boy treated this fracture in this way. I'm not so happy with this treatment because you see we have still some gap here, so the compression is not so good, and I believe that this screw was fixed first. I will mention this later. Okay. Other situation here, you see, again I focus on the closure of the medial physis, as you can see here also on the X-ray. So this is then the picture of the triplane fracture with the model. The closure of the physis you can see also very well in the 2D CT scan. Of course, here the similar situation, CT scan and fracture. But you see again, you don't need a CT scan to make the decision for the treatment. Okay, now the treatment here, you see the closure of the physis on the medial side. Okay, then we make the drawing of the fracture. So on the posterior part, this is a right ankle joint. On the posterior part, we have the Falcon fragment or the Salter-Harris 4 fragment fracture. Then here we have a complete line through the surgical joint surface, and anteriorly we have the typical Tillaux fragment. So especially in a workshop, when you cut this fracture by yourself, then you will understand the three-dimensional pattern of this fracture very well. So you see Salter-Harris 4 cut, Salter-Harris 1 cut, this is the epiphysiolysis, and this is the Salter-Harris 2 cut or the metaphyseal cut. And then you make the breakage, and then you see your fragment and your situation of the fracture. Now to the treatment. You see here I managed the fragment with this guide wire here as a joystick, and then the guide wire for the cannulated screw in an oblique way, as you can see here, and fixed in this way. If the Falcon fragment on the posterior part is very big, then we can use also a second screw, as you can see here, and recognize both screws are from anterior in this way. And then it goes. Here we make a really lag screw situation. Okay, here the clinical case, only with one screw. You see step by step, oblique, and personally I like to make a documentation like this to see the hole in the screw. This shows me later, okay, this was a cannulated screw, and if I plan to remove the screw, I can go with a Kirchhoff wire, guide wire in the hole, and I can closely reduce the fracture. And this is the clinical situation. You can discuss about the second screw, but the metaphyseal part is not of importance. So now I came to the second question. Why can we cross the physis in a 2 or 3 plane fracture with a screw? It is never allowed to cross the physis. Whenever possible, we should avoid crossing the physis. The rest, that means medial part of the physis, is already closed. The closure of the lateral physis is a desired effect. Or can we do this because of 3 and 4 together? Nearly 100 voting. Fantastic. Okay, so I will stop the voting here. So you can see that's fantastic. 50% say 5, and it's correct, but also 3 and 4 is correct, but overall it's an effect of both. Can we have back the presentation? Okay, so I give you also the answer. The medial physis is almost closed or already closed, so on the other hand, the closure of the rest, the lateral part of the physis, is a desired effect. As you can see here, this part is already closed, And of course, we want to have also a closure of these physes here. Now I came to three special parts, as I mentioned before. On the left-hand side, you see the normal, typical two-part or two-fragment triplane fracture. But then sometimes we have a three-part complex fracture, or seldom we have a four-part. Personally, I have never seen a four-part. I have only seen a three-part fracture. But here you see the CT scan, and here you recognize the importance of a 2D reconstruction, because this fracture line here you will never see in a 3D reconstruction. And on the other hand, you see, as a sign of the three parts, here you have a complete Salter-Harris 4 fracture. Okay, here the model, and you see here we have the fragment here, we have the fragment here, and of course, for this fracture, you can manage this fragment closely, but for this fragment, you have to open for lateral posterior to reduce the fracture in this correct way. Okay, complication and pitfalls. Of course, at first, you need a correct diagnosis. Look again at this picture. You have seen the picture before. What's about the fetal situation? This is a very young child. This is a child under 8 years. Widely open physis. Is this a real typical triplane fracture or not? Even we see here a gap. Of course, it is not a typical. And so we have to recognize the physis, and we have to be treated very carefully. And in the CT scan, you see it again, all physes are open. So it's a very young child with a triplane similar fracture. So, what's about the treatment? Look at this treatment. Is this treatment correct in this young child? Of course, you will say no, because you cross the physis here. And here in this age group, it's not allowed to cross the physis. What happens? You see, the correct treatment would be this, for such a fracture, with smooth Kirschner wires in this way and not cross the physis. And here you see what happens. You see, we have a closure of this physis here, and we have a very severe leg length discrepancy in this situation as a complication. Again, the question, which part of the fracture is more important, the epiphyseal part or the metaphyseal part? Of course, the epiphyseal part, joint part, is more important. Therefore, it makes no sense to put in first this screw, then you have no effect on the joint line here. So therefore, you have to go in another order. That means the first Kirschner wire respects the joint line and the article fragment, and if it's necessary, the second screw or pin goes then in the metaphyseal part. Again, complication pitfalls. You see here, what is here wrong? I go back shortly. You see, this is a Tillaux fracture. You see the Tillaux fracture with a very big fragment here and here. And now look please from which direction the screw is coming in. It's a lag screw from medial to lateral. It looks quite nicely here, but the stability, I guess, is not very high here. So therefore, again, do not this in this way. To push it from this way oblique, and then you have a good fixation, and not in this way. So, I come to the summary. Respect the correct position and order of the lag screw or Kirschner wire, as I mentioned exactly before. Again, the epiphyseal part, the first one, metaphyseal part, second one, as you can see here on the picture. In critical cases, as I mentioned before, we recommend performing a CT scan. But normally after my talk, you should be able to make the correct decision, as you can see here. Of course, this is an unclear situation now. Here we go again for a CT scan, and we see the incompleteness of this fracture very nicely. It's a stable situation. Or here, again, is a part of a three-plane 2 fracture with an additional fragment, you see, but not complete. So the CT scan can show you this very nicely, but it's also a stable situation. Of course, we need an anatomical reduction of the joint line, but in the correct way and not in the wrong way. So that is from my side, actually. So we have some time for questions. And really helps me here that we go a little bit from the beginning to the questions. So again, the first question, can you show the question to everybody? Yes? Okay, then you can read the question. Everybody see now the question? This was the question about the plaster cast. Again, in this situation, it's enough to have a lower leg cast. We don't need to go for a long leg cast over the knee. Okay, next question. We can see perhaps. Okay, ready? Show me the question here for everybody. Okay, from Egypt we have a question. If secondary displacement occur, we go to a trial of closed reduction first or go to an operative treatment? This is a very good question. The secondary displacement means not that we have there is no opportunity, possibility to make a closed reduction or that we have other problems. It's only a sign that some immobility situation we have in the plaster cast or additional forces, rotational forces. You believe, you know, we have these forces in the ankle joint, and if in the plaster cast this is not stable, so the fragment perhaps will dislocate a little bit. But anyway, in this situation, in my hand, and I guess also in your hand, a close management is always possible. Okay, next question. When we do allow weight bearing, I focus on this in the conservative treatment as in the operative treatment after 4 weeks, seldom 5 weeks. So there is a question from Peru. If you use cannulated screws, do you need to splint it at all? This is also an important question, a very frequent question. We don't need an additional immobilization like splinting or plaster cast for stability. I apply sometimes a so-called soft cast from soft cast only for patient comfort and pain management. You know, of course, you had a fracture, you have pain, and then you make an operation, even a closed operation. For 2-3 weeks, a plaster cast can solve this problem, but not for stability. It's not necessary for stability. It's stable enough. Okay, the next question is from Romania. How can we access closed reduction if we need CT to assess initial displacement? Yeah, this is also a very tricky question. Okay, on the X-ray you see the fracture, but you are not sure. You are not sure if the gap is over or 2 millimeters or is it severe displacement. So you go to the CT scan. But now after the CT scan, you can make an analysis of your fracture. And we treat the fracture direct on the intensifier. And we rotate the foot on the intensifier. That is the intensifier. And we rotate the foot on the intensifier that we see the correct plane. And then it's very easily to see the joint line is correct. Don't forget, you have on the counterpart always the Tillaux, who gives you the alignment for the fragment. So it is possible, if you have a CT for a assessment, to treat this without CT scan. A small trick, you can make an arthrogram, and then you see the fracture, the joint line. Okay, from Spain. The Tillaux fracture is the Tillaux fracture two-plane or triplane fracture. The Tillaux fracture is the two-plane fracture. It's the Tillaux. He described this fracture. Therefore, In France, everybody say Tillaux fracture, and also in US, very often we say Tillaux fracture and not a two-plane fracture. But Tillaux and two-plane is the same, and three-plane is completely different. Okay, then we have from Israel a question. If on an X-ray you can see only 5 mm gaps, how you can be sure to good reduction? I think I answered this question before. Under intensifier, you see the fracture line, you rotate again, you rotate on the intensifier, you rotate your fragment in a way that you see the fracture line, and then you can close it in this way. From Kuwait, the question, will you still put an oblique screw if you still have an open physis? Remember my last case under pitfall. If the physis is really completely open, I never pass the physis. You remember the case with the growth arrest? No. In this situation, I recommend to use Kirschner wires, but cross Kirschner wires in this way. Again, remember in this way and in this way. And not two parallel in this way. This way and this way. This gives a good stability. From Kosovo, a question, with the oblique screw, can we damage the physis? I think this is now, in the meantime, clear. If the physis is open, we damage the physis, we compress the physis, but in the normal three-plane fracture situation or two-plane fracture situation, we cannot damage the closed fissure because the screw passed across the physis at the closed part. This is from where is this? UAE. Okay. Why closure of later physis is desirable? Again, you know, we are at the end of the closure of the physis, and the physis goes on, so we can compress the not a closed fissure on the lateral side. So we have a similar situation. Here on the medial side, we have the closure. Now the fracture is here. So I like to have now a closure over the whole line. So then, but Diaz Sepulveda from Chile, what do you, what you can read the question, what do you do in a three-part fracture with anatomic direction and stabilization? Again, the anterior part, the Tillaux fragment, you can manipulate this always close. But the posterior part, that means the so-called also in adult, the Volkmann fragment, you have to open the joint. And I do this personally from direct behind the fibula from lateral posterior, and then I go to the joint, and I look only to the joint, not to the metaphyseal arch, and then I give a compression screw. From Jordan, of course, this is the question about full threaded screws. You know, if you have followed perhaps 20 years ago AO courses, how we apply compression screws, we drill a bigger hole, a smaller hole, but here is another question. If you reduce the fracture with a clamp, compression clamp, of course, then you make only a neutralization of the fracture. Then you don't need the cantilever screws. From the Sudan, what is the recommended size of the cantilever screws? This is a very important. Of course, these are mostly adolescent patients, so that means around 12, 14, 15s, around 40 kilograms, 50 kilograms, 60 kilograms. So depending on this age, I am using 3.5 to 4.0, seldom 4.5 cantilever screws. The majority are 3.5 and 4 millimeter screws. Next question from Brazil. When you do suggest fixation of the fibula, short because of the posterior fibula ligament, don't permit the reduction of the posterior surface of the tibia. I guess if you have this situation, you have a really adult fracture. I never, over 40 years, and now I have really 40 years of experience, I never have seen a triplane fracture where the ankle joint was not stable. I guess in this situation, and this needs also, again, a very careful assessment of your fracture. That means look at the age of the patient, the gender of the patient, the situation of the growth plate, the bony condition, and then you see, oh, this is not a typical triplane, this is an adult fracture. From Santo Domingo, you realize it is in mini open or total open, the fracture has 2 fragments. Mini open or total open, of course, if you go for an open treatment, what I do not recommend, I make this decision before. I know if it's a fracture with 2 or 3 fragments. If I have 3 fragments, of course, I go by mini open or total open management, reduction and fixation. But if I have the typical situation with 2 fragments, the main fragment and the Tillaux or Triplane fragment, then I do this mini open, or as I explained before, in a closed manner. From the Emirates, if there is a lot of edema around the ankle, for how long you can delay the surgery? Oh, this is also a very important question. In our house, this is never, really never emergency surgery. That means if the ankle is not, joint is not so severely swollen, I do this planned and the next or over next day as an outpatient clinic. That means day surgery. If I have a very swollen situation, I make a plaster cast, a splint, send the child back at home for 1 week or 10 days, and then I do this after 7 to 10 days. This is no problem. The plaster cast, I recommended, as I said before, I guess we answered this question, around 4 weeks, never 5 weeks. 4 weeks is enough. Okay, time is running very fast. We have a lot of other questions. I guess we have to come slowly to an end. And I will go through all your questions, and I will answer you by writing your questions so that we can come now to an end. So already can we come back to the presentation? Thank you very much. So my take-home message from this session here about triplane and two-plane fracture, again, respect, and this was also one of the questions, you see, respect the correct position and the order of the lag screw or Kircher wires. Again, in critical cases, we recommend performing a CT scan. We go not to the MRI. It is you have to recognize it is a 3-dimensional fracture in 2 or 3 different planes. And this fracture, even the nearly closed growth plate is closed by screws, no growth arrest will occur. Why? We should see this. No. We have the closure of the physis. And the joint surface, again, remember, is the point of our interest and not the metaphyseal part. That means even you see in X-ray a gap in the metaphyseal spike, this has no effect. Okay. So therefore now, after 1 hour, I thank you very much for your attention. And I hope we can continue next year with our pediatric webinars. And I hope you could profit from my talk. You go back to your hospital, you look your triplane fracture a little bit perhaps with different eyes, and you are able to analyze this fracture absolutely perfect. Thank you very much. Goodbye.